I'd like to transition now to recurrent ovarian cancer. Unfortunately, almost 75 to 80% of patients with advanced ovarian cancer recur, and when they recur, unfortunately, they ultimately succumb to their disease. The fortunate scenario, though, today is that they have multiple options, and patients are living longer and longer. If it hasn't dawned on you, the prevalence of ovarian cancer is 10 times the incidence. So the incidence of ovarian cancer is about 20,000 patients, but there are 10 times that, 200,000 patients in the United States living with recurrent ovarian cancer, quite frankly, battling it. Tell me, Matt, how do you, what are the factors that determine how to treat recurrent ovarian cancer? What are the key factors?
Well, I wish I knew the answer to that question. I can tell you the factors I use. Whether they're the right ones or not is really the question.
All right.
You know, certainly we want to make sure, is it a low-grade tumor, high-grade tumor? How long has it been since?
Histologic subtype, okay?
So histologic subtype.
Platinum-free interval.
Platinum-free interval. And so the big biomarkers, and what side effects
Molecular
they had.
signature.
Molecular signature we talked about. We want HRD. We certainly don't want to neglect looking for MSI, mismatch repair deficiency, although rare. Our endometrioid subtype might be one that we would want to be looking in. And then thinking about side effects from prior therapy.
Okay.
And then the goals of care. And a lot of the goals of care, do they want to travel, they want to lose their hair, do they have a wedding coming up? There's a lot of things that factor into these decisions we make.
Histologic subtype, platinum-free interval, molecular signature, number of lines of therapy, pre-existing toxicities, and the goal of treatment. 6 things. I love it. Thank you. So in the olden days, Dave, we used to talk about platinum-resistant and platinum-sensitive recurrent ovarian cancer. He didn't mention that. Is that still a valid concept?
Well, Matt's very cutting edge. The terms are still...
That's why I asked him.
I'm old school, baby, old school. You know, those terms are still used, and we need some guidelines. However, these...
So define them.
So I think right now we used to talk about 6 months of treatment-free interval or platinum-free interval, but that's been modified as we're using maintenance up front. We still use the time from the last platinum drug as this random 6 month, but really probably 3 to 12 is better, and that will probably be modified in the future as we have more and more maintenance therapies.